Thank you, and I appreciate everyone's patience for waiting to my talk. I will try to keep this as informative and brief as possible. Newborn screening, what have we learned, or what should have we learned, and where are we going? Same disclaimer as before. Now, when I talk about newborn screening, I talk about the use of unselected testing in the general population. That is, not picking out babies because of a family history, but yet any baby born in the nursery having this kind of testing. And when you talk about newborn screening, you really can't do it without talking about PKU. I will try not to belabor PKU, although that's one of my first loves. And you can't talk about PKU without talking about Robert Guthrie. Dr. Guthrie passed away a few years ago. Interesting man. He was an internist. Actually, he was a microbiologist. He was not a pediatrician. He was not a geneticist. He was not a biochemist, but he had an interest in mental retardation, became interested in PKU, and developed the first mass screening test for hyperphenylalaninemia, known as the Guthrie test. And the most important thing I think that Dr. Guthrie did, first of all, he said that he showed that you could do mass screening on newborns relatively inexpensively using dried blood on filter paper spots. And some people say that despite all of Guthrie's great achievements, the thing that he probably contributed the most is actually using filter paper as a vehicle for sharing samples in large numbers. Seemed like a good idea at the time. Like most of history, if you dig very deep, it's not beautiful. But there are a lot of controversies about doing newborn screening and government intrusion into medical practice, et cetera. In fact, almost all organized medical groups were opposed to newborn screening when it first started because they thought it was interference with medical practice. Obviously, those were misguided sentiments, but that's kind of where we were. Anyway, the thought was you'd screen all the newborns despite family history, you'd identify pre-symptomatic newborns, start therapy, and in the perfect world and in the world of PKU, largely prevent mental retardation. Learned a couple things along the way. One is that technology can drive newborn screening. Dr. Guthrie showed us that it's possible to do testing on dried blood spots. One of the most important things, however, is the power of consumer advocacy groups in driving public policy and in driving newborn screening. Control studies are great. Almost no control studies were done about newborn screening back in the olden days. And once you get a test on the menu, it is exceedingly difficult to ever get it off of the menu. An ugly secret. In spite of some of the wonderful words today about curing the genetic disease, we can treat a lot of things. We can't cure many of them. Things we can cure are things that you can do transplants for, et cetera, but you can't really cure lysosomal storage diseases with enzyme replacement therapy. And I hazard to say, based on animal models, can't cure it with gene therapy either. But you might be able to ameliorate the complications thereof, and we might be able to make people's lives better, which I think is a noble goal in itself. Now, what was included in the newborn screening back in the ancient days? Well, it sort of depended on where you lived, and that was too bad. And even now, it still depends on where you live. Newborn screening policy is set on a state-by-state basis. There are national guidelines and national recommendations. This started in 2004, a collaboration between the American College of Medical Genetics and HRSA. Came up with a list of recommended tests. A very elaborate process was undertaken to come up with this particular list. I won't tell you all the details about the process, but in Virginia, which is where I practice, this is the current list. There are a couple of things on here. What's on this slide here are all things that are biochemical analytes. That is, these are compounds that are present in blood. And shown on this list are some other compounds present in blood. Shown in red, yellow, and blue are either proteins that are measured, or enzymes that are measured in the light blue, or hormones that are measured. And the reason that these are important is that the things that have to accumulate are time dependent. That is, if you do a newborn screen on a brand new newborn freshly delivered, chances are most of the things that require accumulation over time will not be valid because you've not allowed enough time for things to accumulate. Not true about proteins. You can do protein and enzyme assay on cord blood if you wanted to. That would be accurate. Hormones a little bit different. The problem with hormones in newborns is they vary dramatically with gestational age and with chronological age. So, this committee existed, came up with the big list, and the committee still exists, and this is the most recent set of recommendations, several of which have been implemented in many states. Virginia has agreed to start screening for severe combined immunodeficiency, also screening for critical or cyanotic congenital heart disease, not done off of blood spots, done off of oxygen saturations. And Pompe disease has also been approved on a national level or recommended on a national level. Other things that have been recently considered but not recommended thus far, things like Krabbe disease and hemoglobinopathy, another hemoglobinopathy rather, and then chronic bilirubin encephalopathy. Now I mentioned Pompe disease because there's a lot of interest in enzyme replacement therapy at this conference. And Pompe disease probably makes the most sense of all of the disorders for which we could potentially screen as a lysosomal storage disease. As most of you probably know, there's infantile onset and late onset forms of Pompe disease. Turns out that these are much more common than anybody ever appreciated. Pompe disease, as you I'm sure know, is autosomal recessive, deficiency in alpha-glucosidase, and a huge spectrum of diseases. And it's not only a neuromuscular disorder, it's also a cardiac disease, particularly in the newborn infants who present clinically. Newborn Pompe disease is a catastrophic condition. Children are quite hypotonic, have cardiomegaly, cardiomyopathy, and respiratory insufficiency, and will usually die within a year of life if untreated and if not mechanically ventilated. This is a survival curve for the infantile onset Pompe disease shown in the green and the later onset Pompe disease shown in the blue. And the notion is that if you could pick up the babies early and treat them with the enzyme therapy that's now available, you might be able to make a big difference. A lot of interest in screening for lysosomal storage diseases in newborns. And one of the notions is that if you could pick up babies or adults even before they became symptomatic, maybe we could prevent the complications or at least slow them down dramatically by enzyme replacement therapy. One of the big controversies is how much of a developed complication can you expect to reverse? And that's one of the things that's making discussions of newborn screening for lysosomal storage disease quite lively. Turns out that there are pilot programs underway, and in fact a handful of states have already adopted newborn screening for lysosomal storage diseases. Now, most of the assays are a bit complex, unlike most of the newborn screening tests now done in states that use tandem mass spectrometry. Most of the assays being done for lysosomal storage diseases are multi-step. Doesn't mean it can't be done, just means it's a little bit more complicated. One of the big problems though with newborn screening for lysosomal storage diseases is that for many diseases, there are early onset or neonatal onset forms and also adult onset forms. That is, if you screen a child for an infant for Pompe disease and it's positive, does that child have infantile Pompe disease? Well, maybe if they're symptomatic. Or is that child going to develop symptoms at age 30, 40, or 50, even if unrecognized and untreated? We don't know that. Hopefully, eventually, there'll be better genotype-phenotype correlation to be able to make that kind of prediction, but this is one of the big problems. Even a big problem now, if you've got a family with Fabry disease outside of newborn screening, when do you start treating the affected boys? Do you start them immediately? Do you start them when they develop proteinuria? Again, very complicated. My personal bias is you treat them as soon as you make a diagnosis, but there are people who would argue that you should put this off for a while. Problem with that is I'm not sure of how many things on that timeline I showed you are going to be reversible. I would just assume they never develop. Now these are as of 2013, these are the states that were either doing or planning to do newborn screening for lysosomal storage diseases. Again, relatively controversial. Some of these were pushed through by legislators without a lot of input from physicians. Others were physician driven. The other big question that comes up in newborn screening now has to do with whether we should get away from enzyme assays and analyte assays like we're doing now for PKU, et cetera, and move straight to DNA-based testing. Analyte and enzyme assays are the gold standard. They've been around for a while. Sometimes age or diet dependent. Enzymes can be quite labile. Galactosemia newborn screens are notorious for being falsely abnormal in the summertime during hot weather. False negatives sometimes occur. Usually doesn't identify carriers, which is a good thing. Turns out this is a little bit less expensive. DNA testing, however, is not age dependent or diet dependent. DNA is stable. There should be fewer falsely abnormal results. Unfortunately, you may identify carriers. Do you want to do this? I don't know. If you know the infant is a carrier, then who's going to tell that child that information and at what age? Most diseases have multiple mutations, so you might be able to screen, say, for 40 cystic fibrosis mutations, but you'll miss the other 1,460 that have been identified. That's kind of a problem. Test sensitivity may go away. Right now, we treat most of our patients based on analyte levels or enzyme levels and not necessarily on the specific mutation that they have. That's a problem. And right now, DNA testing on a broad scale is much more expensive than analyte testing, although that may change when technology improves and gets cheaper. And then the next thing that's come up is genetic counseling from newborn screening. Right now, we do newborn screening for the benefit of the infant being screened. And in most states, it is done without informed consent for the parents. And the rationale is we're doing this for the good of the baby. And we're going to make the baby smarter. We're going to make the baby healthier. This is a good thing. If you start doing screening for carriers, however, that's a different story because now you're not necessarily doing it for the baby's benefit and to treat the baby. Right now, carrier identification is by default. You identify a child with an autosomal recessive diseases. By default, you've identified the parents as being a carrier. And right now, only hemoglobinopathy screening and the two-tiered cystic fibrosis screening will reliably identify carriers. That will change if we move into DNA testing in a big way in newborn screening. Carrier identification has been a byproduct of newborn screening, but at least up until now has never been the sole intent of doing newborn screening. There are people out there, however, that are advocating that we change the focus away from just treating children doing carrier screening. Personally think that's not a good idea and has a lot of ethical pitfalls. So the questions to ponder is how common should a condition be to warrant newborn screening? 1 in 3,000 like cystic fibrosis, 1 in 100,000 like homocystinuria, which is on most newborn screening panels in most states, or even less common than that for rare conditions. How treatable should a condition be? Treatable in the sense of managing all the complications or treatable in the sense of palliation? Because there are conditions out there that we can palliate, but we may not treat effectively. That's difficult. And then the other big problem has to do with the blood spots. There's a great controversy in some states about who owns the blood spots, about privacy, etc. And many states destroy the blood spots after 6 months just to avoid these kinds of issues. And I think that's the policy in Virginia. Again, we're now doing newborn screening without informed consent, but should we start getting informed consent, particularly if we're screening newborns for adult onset disorders? And then, as I mentioned, should we be doing newborn screening solely for the purpose of genetic counseling without regard to being able to treat infants? We've learned a lot of things. Technology can drive screening. Pilot studies would be great, weren't frequently done. Advocacy groups are a very powerful force, and I submit the most powerful force in changing newborn screening policy. The more tests you have, the more false positives you're going to have. And politics and public opinion sometimes trumps good epidemiology and good science. And this was a statement from JAMA in 2014. 2013 was the 50th anniversary of newborn screening for PKU. 1963 started in Massachusetts. And in 2014, there was an article in JAMA about this, JAMA Pediatrics anyway, that talked about some of the controversies, et cetera, but still thinks newborn screening for treatable disorders is a great idea. And with that, I appreciate your attention and I hope we can have dinner.